Hello, I'm joined by Associate Professor Bert Jun from the Wilmot Eye Institute. We'll be talking about endothelial keratoplasty. What is your strategy? So in this lecture, I'll be proposing a series of multiple choice questions on endothelial keratoplasty, and I'll be discussing with Bert his usual technique as well as my usual technique. And we all know that techniques can vary according to the individual patient, and we'll talk around that. There are, of course, no right or wrong answers, and a lot of the techniques that we're using now may well be different to the techniques we use in a few years' time. So let's begin. Question 1. What's your preferred technique at the moment? Either DSEC or DSAC, DMEC, DMAKE, or if you've got some other techniques that you're doing at the moment?
Well, I think basically I'm doing about 50-50 DSAC and DMEC. So options 2 and 3 here on the slide. And it really comes down to I think what the patient's needs are and what surgery is best suited to a particular patient. I think that the vision is better with DMEC, at least in terms of the studies and in terms of my own experience. But I think the bigger issue there, as people have been dealing with, is the detachment rate is higher and the rebubbling rate is higher. And then the last thing is sometimes patients will come in and they'll be, 20 over 50, and they'll have frank edema, and they'll be kind of hemming and hawing about whether they should have surgery or not. And a patient like that doesn't really need, in my opinion, to see 20/20. So I'll basically put it to the patient and say, you can see a little bit better, and I put it to them basically as a line better, somewhere between 20/25 and 20/30 for DSAC on average, and somewhere between 20/20 and 20 over 25 on average for the DMEC patient. So it's one line of difference on the chart. There may be other issues related to contrast sensitivity or functional vision that we don't really address directly. But the trade-off for that is that the patient has to be on their back for 24 hours versus, again, the better part of 5.5 days. So sometimes I'm actually making the decision for the patient. Again, if they come in with bilateral frank edema, they're seeing 20/40 or 20/50. They've been like that for a couple of years, according to the records. And, a patient like that, I think, would just be greatly benefited by having a DSAC with much less inconvenience.
If you enjoyed this lecture so far, please subscribe to http://iop.vision. I hope you enjoyed this series as much as we have putting it together. Thank you.